So without further ado, it gives me a great pleasure to introduce Matt Quint, who's a physiotherapy clinical specialist at Portsmouth Hospital. He has an academic and clinical role in both the hospital and with home respiratory support. Matt's leadership skills span the intensive care to the community, and he has a solid research background in drug delivery, cough and aerosol droplet therapy. He's been a wide and highly spoken and fantastic representative for respiratory physiotherapy and is a key participant in the ACPRC. So without further ado, I'm going to hand over to Matt, who is going to talk about the role of nebulization and humidification for airway clearance. Thank you.
Thank you for that kind introduction, Michelle, and thank you for the opportunity to talk courtesy of BRIAS. I'm looking forward to the chance of sharing some thoughts and some ideas around aerosol science and drug delivery, well, in this case, aspects of drug delivery that can improve airway clearance.
So what I wanted to talk about was a few things in terms of this talk. I was going to talk about aspects of normal ventilation. I wanted to discuss aerosol generation, how we generate it in various ways for therapeutic uses. I need to consider the aerosol science and how it deposits in the airway and what its relevance is to airway clearance. What I'm not going to cover is areas outside of my but to a degree outside of my clinical expertise. I'm not going to talk about peds. I don't work in a pediatric setting. While I have some experience with CF, that is outside of the concepts of the areas which I wanted to talk about today. And I will certainly not be talking about primary ciliary dyskinesia or the ventilated patient, although my background is within critical care. Now, it's worth noting that we've been doing this for quite some time, and this is a picture of a ceramic Nelson inhalator. It's a very old-fashioned device where boiling water was put into a ceramic jar, and the individual inhaled this through a mouthpiece, and that allowed them to inhale various agents, typically something along the lines of menthol. Now, it does age me somewhat that within my first job within the NHS, these were still being used, and they're still available. You can still buy them on the internet. I've regularly seen them on Amazon, but suffice it to say they seem to have dropped out of favour, certainly within the NHS in the UK. The next point I think is really important to consider is mouth care. Mouth care is a key part of airway clearance that is frequently neglected. If you have a mouth which is dry, full of crusty secretions, it is going to be very, very difficult to clear your airways. And as I've investigated this more and more, I've recognised that this is an important area. And other professionals will highlight this as well. My speech therapy colleague is passionate about ensuring that we provide appropriate mouth care, not just for airway clearance, but also to aid communication. So I'm going to talk to you today about two patients. Patient number one was a gentleman by the name who we'll call Bob Fleming. He's a 74-year-old gentleman with COPD and bronchiectasis, and he was admitted to our emergency department with a history of increasing shortness of breath and difficulty clearing his chest. He was distressed and becoming increasingly unwell. The next patient is a young lady by the name of Billy V, and she's a lass with severe asthma, and she has had recurrent admissions due to significant mucus plugging, primarily of her left lower lobe. So the questions I would ask myself are, what would you do when you see these patients? What could you do when you see these patients, and what should you do? And there's various ways and approaches that we could adopt as to how we manage these individuals. So what was going through my mind when I went to see these patients? Well, there's a fair few things of agents that could be delivered, things that we can do to reduce their work of breathing, and things we can do to aid expectoration. So that's what we're going to talk about to a degree. Now, what can be delivered to the airways? Well, there's a whole heap of different agents that can be delivered and have been delivered over the years. Never mind the therapeutic agents. I think there's a long historical history of recreational agents in terms of tobaccos or other agents that have been smoked or sniffed, including alcohol, which has actually been sniffed as a nebulizer in some scenarios. So what I think we need to do is we need to think about how a drug is delivered to the lungs, how it is absorbed, how it is delivered, how it is metabolized, and how it is eliminated. And to a degree, you need to think about things like volatiles, as well as volatiles and gases, as well as the aerosols. The things which we would be most comfortable with in terms of delivery to the airways would normally be things like bronchodilators, so the likes of salbutamol, albuterol if you're in the States, or ipratropium bromide. We'd regularly deliver steroids as an anti-inflammatory within the lungs, and mucolytics. We mustn't forget the value of saline and saline lavages as a strategy for having an impact on the airways. And then there are different agents which have also been delivered. We can use the lung as a you can treat it topically, or you can so that's as in treating them with antibiotics or bronchodilators, or you can use it as a system for systemic drug delivery for things like insulin. The large surface area allows the respiratory tract to absorb drugs, and then that can avoid first pass metabolism and therefore improve drug delivery peripherally. So let's start to talk about some of the anatomical factors which can have an impact of how drugs are delivered to the lungs. I love this picture. This is a picture of a cast of the human airways, where each individual lung segment has been coloured differently. And it really shows to me the diversity and the complexity of the peripheral lung, and the challenges of getting aerosols into the distant regions of the lung. So if we consider how air gets into the lungs, starting from the nose and mouth and going down towards the alveolus, it's going to first come in through the upper airway and oropharynx, and this has a variety of functions. It's there to warm and filter and humidify the air so that it protects the distal airway. This is done in terms of the hairs, the turbinates, the highly vascular structures, which mix and cause turbulence in the upper airway, and that turbulence allows the particles to be filtered out. We then come down to the larynx. Now the larynx has three functions. The first of which we'd be most familiar with, and what you're listening to now, is phonation. So that can, as those chords vibrate, they will allow us to generate noises, some of which are intelligible and some of which are not. The ability for the vocal cords to abduct and adduct allows for airway protection, and then clearly the larynx provides a passage for air to pass distally further into the lungs, and actually the changing in pitch of the airway and the changing pitch of the larynx changes airflow through the larynx, so it will add turbulence or reduce resistance. So if you think of, if you're running hard and you need to get air into the lungs, you'll actually be breathing in and out through a much more open and wide larynx as you gasp for air, as opposed to when you're speaking or when you're breathing naturally in that larynx, you won't notice the same level of abduction which is there. Now, there are a variety of models which have been used to look at how air is distributed through the lungs, and this is one which was used quite widely throughout the respiratory and aerosol world. This is the Weibull model. This is a dichotomous branching pattern which goes from trachea as the first area, then down to the carina, which is the first division, and then it divides subsequently, moving down and down and down and down. So it takes 23 divisions to get down to the alveolar level. where gas exchange occurs. So this is one which is widely used. Clearly, because it is dichotomous, and it assumes that the branching of the airways is the same every time, it is not truly reflective of how the airways are, but it is one which is a model which is widely used within the aerosol and respiratory world. So if we're following our model through, as we come in past the larynx, we come into the trachea, which is generation 0 of the viable model. And I think when I was a student, I tended to think of the airways as a relatively static structure that didn't really move. It was rigid and was stationary. And I think if you haven't been to see a bronchoscopy, if you have the opportunity to go, please do. You can see the dynamism of the airways. You can see how the airways extend and contract, and how even the larger airways can collapse down with those despite the cartilaginous rings. So the trachea is about 10 to 12 centimeters long, with a reasonable internal diameter, and it's U-shaped rings that support it. So it is actually a sort of D shape rather than a cylinder, than a true cylinder. So it's flattened, and as I said, this can be compressed along its length and distended along its length and across its length as well. So what happens when the airways divide? Well, this is described as a Horsfield model. So the airway elongates. It goes from, in this case I've taken the concept of a circle because it was easier to use. So the circle becomes an elongated oval, and then it finally separates out. And what tends to happen is that there is a mother and a daughter airway. So the daughter airway comes off at a slightly different angle, so it is not that dichotomous branching pattern that we talked about in the viable model. It is much more of a slightly spinning pattern, and that spin which comes off as a result of the airway coming off at a different angle provides a degree of increased turbulence within the airways, which is again is useful in terms of filtering particulates. And you'll also find that the divisions of airways are points where you can get an increased level of deposition of particulates. And there's been some reporting that you will get tumours growing as a result of particulates, particularly smoke, depositing in that area. We then come down to the segmental airways. These are generations 1 to 4, and the walls are still supported by U-shaped and then helical shaped areas of cartilage, and again these can collapse under a degree of pressure, especially when coughing. We then come down to the small bronchi, generation 5 to 11 in our viable model, and these are still supported by cartilage, but also supported by pressure gradients. And then the diameter it falls from around 3.5 millimeters to 1 millimeter as each area divides further and further. Generations 12 to 14 are in the bronchioles, and here that we no longer have the cartilage supporting the patency of the airway. Here it is supported by the elastic recoil of the lung, which is pulling the airways open. Down to the distal airways, generations 5 to 18, or the alveolar ducts, 19 to 22, or the alveolar sacs, generation 23. This is where the true gas exchange units occurs within the lungs. And these airways are supported by pressure gradients and the role of surfactants. Now, I put this slide in because we need to consider the level of resistance of some of the airways. So if you think about the trachea with its large diameter, breathing in and out through a large tube, you would imagine that would provide far less resistance than breathing in and out through the small bronchioles around 1 millimeter in diameter. But this isn't entirely true, because whilst the airways divide further and further and further as you go down, you get an exponential increase in cross-sectional area, and it's that cross-sectional area and the resistance which is brought about by that reduction in, or as the cross-sectional area increases, the reduction to flow decreases, and so the majority of the resistance of flow comes from the upper airways. So, but by the time you get down to the acinus, the true gas exchange unit of the lung, there is a large surface area, a large cross-sectional area, and minimal resistance to flow. And I love this picture of it's a rabbit lung, showing that huge surface area as the terminal bronchi reaches the gas exchange units. Now, if we're going to understand how drugs or particles are delivered to the lung, we need to understand some of the fluid dynamics. Now, I make no claim to be a mathematician, and as you can see here, some of it does get a little bit complicated, but I'll talk about some of the principles, and we won't get lost in this level of detail. So it's worthwhile thinking about normal respiratory patterns and the flexibility that we have when we're breathing in and out. So we will be breathing at tidal volume, but we always have that ability to breathe in at a larger volume, and that will change how we're breathing. So this is, we're not just talking about a unidirectional flow, we're talking about a bidirectional flow with changes in velocity and changes in volume, and dependent on what the individual requires. So if we think about how fluid flows through an environment, there's two primary ways that this can be described. A, on the left hand side of the screen, is a laminar flow pattern. So this could be thought of as a canal with straight walls and a smooth floor, so that the water flow or airflow through that is a very efficient system with no additional changes in pattern. Section B on the right hand side of the screen, well, this is turbulent flow. This is more like a little babbling brook or stream, where you have rocks and changes in direction which cause current flows and little turbulent changes, and that is provides more resistance to flow. So the question is, which do we think occurs within the airways, and why? And when I put this to people, most of the students would turn around and say, well, of course it's laminar flow that we want, because that's a more smooth, more efficient flow, which provides less resistance. Well, actually the opposite is the case. Now we talked about the anatomy to start with, and the structures which you have, so the nares, the hairs, the turbinates, all are there to provide turbulence, as does the larynx, as does the corrugation within the trachea, and that is there to provide an extra filtration which is going on. So the whole point of the upper airway is to cause as much turbulent flow and resistance to flow, so that we can filter out the particles which are there, and that's what makes it so challenging to deliver drugs to the lung. That's why we get such a poor deposition rate when we're giving drugs to the lung. Now, coming from Portsmouth as the home of the Royal Navy, I needed to put some sort of demonstration of this in, and the fluid dynamics in terms of Reynolds numbers and the transition from laminar flow to transient flow can be seen beautifully on the hull of this submarine. You have this nice smooth flow over the initial part of the hull. It then goes to a transitional flow where you're beginning to get the eddies and the breakup of the pattern, so you can see the white, the foam, and then when you get into truly turbulent flow, that is where we have the white foam from the real turbulent flow. So we can describe the Reynolds number and the transition from laminar flow through transitional flow to turbulent flow with a figure. As I said, this is the Reynolds number, and this looks at the velocity of the fluid, the diameter of the tube it's going through, the viscosity of the fluid, and the density. Or it can be the surface which the fluid is moving over, as this concept is used in ship design as well as within respiratory medicine. So this gives us a figure, and laminar flow has a lower number and turbulent flow has a higher number above 4,000, and then we get this transitional figure in between. Another way of describing gas flow is the Hagen-Poiseuille equation. So this relates to the level of resistance, where if you have a longer tube and a smaller radius, and the viscosity will all change how that gas passes through the length of that tube. So if you have the radius reduces by 2, the resistance will go up by the power of 4, so it's up to 16 times. So it's a significant increase in the resistance. But as we said, this all depends on is assuming that we have smooth cylinders with unidirectional flow at a constant velocity. Now we discussed this earlier, that with the spirogram that we demonstrated, that we get changes in airflow as you go from tidal volumes. Just the inspiratory and expiratory flow means you get changes in the acceleration and deceleration of gases. As you go to different respiratory maneuvers, so as you take a deeper breath in, that's going to change the pattern of airflow within the lungs. So all of this will impact in terms of the level of viscosity, the level of resistance to flow, the changes in patterns of deposition within the lungs. So in terms of clinical relevance, we've described the majority of the turbulence which occurs within the upper airways. This enhances particulate filtration and ensures that gases are thoroughly mixed throughout the lungs. Now, the world of engineering has spent a lot more time looking at airflow than the world of medicine. So if you think about your average 1 litre car going down the motorway, revving at 5,000 revs, it's going to get through 5,000 of litres of air per minute. So the automotive industry has spent quite some time looking at computer flow dynamics, but this has been applied to the airways, and this is a piece of computer fluid dynamics which demonstrates different areas of turbulence throughout the lungs. So where it is red, you have the highest changes of pressure as opposed to blue, so you get changes in the level of turbulence in different airways as the air is flowing through this in one direction in this case. So how can we predict whether a particle is going to impact? Well, there are a variety of laws, and Stokes' law is one which is frequently considered, where the likelihood of an impaction, F, it depends on the viscosity of the air, the velocity of the particle, and the diameter of the particle. And a lot of the time, I think when we're considering the deposition of particles in the lungs, I like to think of this as a bus going through a narrow lane versus a bicycle. So the bicycle may have lower velocity than the bus and smaller diameter, so it can weave in and out through the traffic more effectively, and heavier traffic would equate to a higher level of viscosity within the air. So how do we generate aerosols to deliver to the lungs? Well, there's a variety of strategies. You can have metered dose inhalers, which are getting rather old these days and will soon be replaced because they're dependent on carbon-based aerosol generation systems. Dry powdered inhalers, which depend on the inspiratory flow which is generated. Jet nebulizers, ultrasonic nebulizers, and vibrating mesh nebulizers. So this is a jet nebulizer. So a jet nebulizer is dependent on the flow going through the system. So if we look at the flow coming in through the bottom, that will go through a narrowing. That narrowing causes a higher flow. That higher flow, according to the Bernoulli effect, generates a lower pressure. That lower pressure sucks up the liquid which is below, and then that liquid is, as a result of that, broken up into an aerosol. Now that aerosol has a very wide spread of particle sizes. It's a very heterogeneous aerosol size. And in fact, that heterogeneous aerosol can't be measured with a normal distribution. So what we'll start to talk about in terms of particle sizes is the mass median aerodynamic diameter. So that's the median mass of the particles, which gives the most mass to the aerosol stream. Because if you think about it logically, a large particle with will have considerably more mass than that small particle. The baffles in the jet nebulizer do reduce the level of particle size which is generated, but there will still be a few large particles which are generated at the same time. An ultrasonic neb relies on a piezoelectric cell placed underneath the fluid, and that wobbling of the liquid base generates an aerosol. Now these aerosol particle sizes tend to be smaller and a bit more consistent than the particle sizes which are generated from a jet nebulizer, and then you need a flow of gas to take that into the patient. The problem with these is that they tend to be rather large. They need a power supply to go along with them, and they've traditionally been used for things like sputum induction rather than standard therapeutic practice. What is becoming more widely available and widely used is a vibrating mesh nebulizer. This still relies on an ultrasonic system to vibrate the mesh, but the mesh has a series of small holes which have been put into it, and then that forces the liquid through, and this means that you get a more consistent particle size which is generated and then can be delivered to the lungs. These have the advantage that they're small, they make no noise at all, and they generate a very soft mist which is inhaled by the patient. That can be inhaled by a patient who is spontaneously ventilating on non-invasive ventilation or who is intubated and ventilated. So in terms of the advantages of nebulizers, these are the great. You can aerosolize a whole different variety of drugs. You can aerosolize mixtures of drugs. They don't really require the patients to do anything other than be able to breathe. They're useful in patients who are young or old, and you can change drug concentrations, and the drugs can be modified. And all the patient needs to be able to do is generate a normal breathing pattern. Disadvantages, well, they can take some time. The equipment, certainly if you've got things like an ultrasonic neb, it's large and cumbersome. There is potential for drug to go into the eyes, and one of my real bugbears is this kit needs assembly and cleaning. Now it should be that these nebulizers should be cleaned and air dried after every use, otherwise we're increasing risk of infection, and I can pretty much guarantee that the majority of us are in environments where those nebulizers are not cleaned after every use. I'm forever having discussions with nursing staff suggesting that the nebulizers should be cleaned and air dried. So we've generated the aerosol, and how does it deposit in the lungs? Well, I've alluded to my bus versus bicycle analogy, and there are a variety of systems. So impaction, sedimentation, diffusion, and then there is interception and also electrostatic precipitation. So impaction is the bus which is just carrying on down the road, and it hits the wall of the road, which is just going off at a slight angle. Sedimentation is the air coming through, and then it just drifts down. Diffusion is where you have an area of a mist where you have a high concentration and to a low concentration, and so the aerosol will drift to the area with a lower concentration. Interception is a little bit like impaction. It's just the almost the glancing blow as the bus travels down the road. And then there's electrostatic precipitation, and particles which are relatively small can be interacted with. So it's akin to the impact of rubbing a party balloon on your jumper and then holding it up to your head and looking at how that attracts particles, your hair in that case, towards the balloon. And this is a reason why any nebulizing or aerosol equipment which is cleaned, and they should be cleaned as we've said, should be air dried rather than polished to a shine, because that polish will add an electrostatic charge and change the deposition patterns that will happen as a result. So what dictates deposition within the lungs? Well, there are three things which we need to consider. There is the particle size, there is the respiratory manoeuvre, and then there is the presence of airflow obstruction. So if we go back to our bus-bicycle analogy, the bus is a big particle size which can't necessarily get through traffic, therefore doesn't get very far, whereas the bicycle can manoeuvre very quickly. The respiratory manoeuvre will be analogous to the speed that things are moving. So if you have things which are a fast moving bus won't go through traffic, whereas a slow moving bicycle will get through quite nicely. And then you have the presence of airflow obstruction, which might be sputum, or in this case is heavy traffic, and that's going to slow slow the progress of things going through to the lungs, and in this case it reduces deposition, so you get more proximal deposition as a result. So to summarize this, there are a number of things which can impact on how an aerosol is delivered to the lungs. We need to look at the liquid, how it is formed, how it is formed as a solution, what its viscosity is, what the concentration of it is. We need to look at the nebulizer function, whether that's a jet nebulizer, an ultrasonic neb, or a vibrating mesh neb. And actually we need to consider what the driving gas is, because that can change particle size as well. So if you were to use a novel gas like a helium-oxygen mix, that would make a real difference as to how the fluid dynamics would work. So we need to look at the properties of the aerosol itself, the particle size, the shape, the density if there's a charge, and then think of anatomical factors, and all those combined together to have an impact in terms of how we get deposition of inhaled agents within the lung. So what's the clinical relevance of all this? Well, I have here some data which shows how we can change ventilation patterns and how that can have an impact. So this is some imaging from some research which I was involved in many years ago. This is looking at the impact of posture and changes in ventilation patterns, and it's a radioisotope study. So the individual had inhaled an aerosol labelled with technetium in 3 positions: in a sitting position, in a supine position, and a side-lying position. So the top pictures demonstrate the planar imaging of where the aerosol was going, but that didn't show the whole picture. Tomographic reconstructions, as this was SPECS data, show differences in terms of the apex and base and left and right lungs. So you can see within the case of the lying on the right hand side, there was a significant dump of aerosol within that lung. So we can have an impact in terms of how nebulizers and drugs are delivered into the lungs. So we need to think about what we are going to deliver to the lungs. And this differs in terms of if you're delivering something like saline versus a bronchodilator. The receptor sites for salbutamol are different from the receptor sites for ipratropium. We need to optimize the airways. We need to optimize the ventilation and lung volumes and the respiratory maneuver for that individual. So moving on to humidification. So this is adding water into the inhaled air, so that can be water vapor or an aerosol particle, and what's more accurately, water vapor which we're delivering to the airways. And this has an impact on mucociliary clearance, and I love this little GIF which is on the left, wafting particles up through the the airways, it kind of shows mucociliary clearance in action. And on the right hand side of the screen we have an scanning electron micrograph which demonstrates the ciliated epithelium with a gel layer over the top of it. And now if we have a look at this video, this is courtesy of our friends at Fisher and Paykel. This demonstrates how you get changes in terms of mucociliary clearance with reduced humidity after a period of time. So the screen on the left is showing how you're getting a good level of mucociliary clearance, whereas the screen on the right, after a relatively short period of time, the mucociliary clearance stops. So this demonstrates the importance that we have of having a humidification within the airways. This is a slide demonstrating this in a slightly more schematic representation. There is the base epithelium with the cilia coming out of the top of it, into a sol layer, the liquid layer, reaching up into the gel layer, which can then be propelled by that wafting action of the ciliated epithelium to propel the cilia upwards and outwards within the lung. How do we assess mucociliary clearance? Can we assess mucociliary clearance? Well, there are two ways that this can be achieved. We can do this by, firstly, a saccharin tablet method. If an individual can taste saccharin, you can place the tablet on the inside of the nose if they're laid down, and then you can time how long it takes for the individual to taste the sweetness. Now this is only measuring the fact that they have a degree of mucociliary clearance within the nasopharynx. It doesn't look at the mucociliary clearance in the distal lung. Other techniques, and I've already shown you some pictures of this and how we might achieve this, is by using radio-labeled isotopes. Traditionally this is technetium, which has a half-life of around 6 hours, and that's bound to other small microspheres or human serum albumin, which can be delivered into the lung. Once we've delivered it into the lung, you can then assess it with a gamma camera and look to see how it has moved over a period of time from the peripheral lung to the central lung. So if we go back to our patients, can we see if there's any guidance as to how we might manage these individuals? And yes, there is a degree of guidance. We have the British Thoracic Society, which has made some suggestions of how we might aid patients in terms of airway clearance, although there's nothing specific in terms of humidification and saline nebs, or saline nebs. There is something just to say that the bubble through humidification is inadequate, as there's a lack of clinical benefit and a higher risk of infection. So is there any other information which we might be able to use? Well, we can look at the American Association of Respiratory Care, who are always worth a look. They've generated some now retired guidance about the administration of bland aerosols, so that was saline and sterile water. Now this has been retired and didn't have a huge amount of evidence to support it. One of the issues that I found interesting is that it didn't differentiate between the risks of aerosols in terms of biological active aerosols and non-biological aerosols, and that was something which became very apparent during the COVID crisis. They've also gone on to talk about the humidification in a separate set of guidance, and the key point on this is to actually talk about the levels of humidity which one would want to deliver of around 30 milligrams per litre of air. And then there's another paper which is worth looking at, which is the updated guidance and some guidance around therapeutic agents which one might want to use. And to summarize this, it's essentially saying that we should only really be using DNAs in patients who've got cystic fibrosis. The routine use of N-acetylcysteine is not recommended, and they could find no evidence to support the use of mucolytics post-operatively, and there's no high-level evidence for the use of mucolytics, bronchodilators or mucokinetics in terms of improving airway clearance. So would I use saline nebs with these patients? Well, yes, I would, and I used it in both these cases. It's easy. You have to remember that this is a saline neb is a quick and easy way of giving some degree of humidity into the lungs. And in this case, we used jet nebulizers with both these individuals. There is some points to remember as to what happens to that aerosol as you go through that process of nebulizing. What starts as an isotonic solution will change over a period of time as you drive more and more of the water off, and you evaporate the water but not the salt, so it becomes a hypertonic solution, and therefore there is a risk that you can get the irritation of airways with hypertonic saline even with a normal saline nebulizer. Do the guidelines support it? Well, the AARC guidelines did support the use of normal saline nebs, but with very little data, and the BTS guidance was a little equivocal. If we look at some of the other evidence, often people have considered using normal saline as a placebo, and to address this question as to whether this was actually a placebo or not, Khan and Adrissel came out with what was quite an elegant paper in some respects. They had 40 patients which they studied following a hospital admission for exacerbation of their airways disease, and these were quite significant patients with a mean FEV1 of around 30% predicted. They were randomized into one of two groups where they received a nebulizer of either 4 mils of normal saline via an effective or an ineffective nebulizer, and that blinding by using essentially a useless piece of kit was quite a neat approach, I thought. And 65% of those patients giving the active nebulization reported some benefits, as opposed to only 5% of those with a placebo group. So this would kind of support the concept that nebulized saline has some benefits in these patients, and that was consistent with the experience with these patients. Hypertonic saline, would I use it in these cases? Well, yeah, again, these were cases that we considered using it, but it is not a benign agent at all. There's this lovely review by Mark Elkins which is worth looking at, how does it work? Well, in theory, the hypertonic saline is capable of disrupting the ionic bonds within the mucus gel that can cause a cough, and the higher concentration of salt will draw water into the airways and therefore make sputum easier to expectorate. But it is worthwhile bearing in mind that the hypertonic nature of the liquid can cause irritation of the airways, and certainly Billy was very intolerant and had a significant level of bronchospasm when we delivered this to her airways, so it wasn't an option with her. If we consider the mechanism which is of drawing water in, there's a nice paper recently by Kelly et al, and they looked at the value of different isotonicities. This is published in the EIJ Open Research this year, and they had a model of sheep's trachea, and they looked at changes in actual depth of the sol layer as a result of the fluid which is coming into the airways, and thus improving the level of mucociliary clearance. So the take-home message is isotonic saline can be delivered with high flow humidified air, and that will change how the mucus is transported by changing beat frequencies. And then there's N-acetylcysteine. Well, is there some evidence, and would I use it in these cases? There is some evidence to support its use. It's been used as an oral preparation, and with some reasonable data to support its use in a small population. But I think it's worth remembering that this stuff is not particularly pleasant stuff to inhale. How does it work? Well, it works by having an impact in terms of the disulfide bonds within the mucoproteins, and therefore lowers the viscosity of the pulmonary secretions. So what data is out there? Well, I think we need to go back to a paper by Gallen in '96, which demonstrated its efficacy in patients post-thoracotomy. and to reduce the level and improve the level of airway clearance. There is some more recent work which has been published by from Iran, which demonstrates its value as a small randomized controlled trial, and then there are case studies of its use in terms of ventilated patients to improve mucus plugging as a direct treatment for mucus plugging. Now, there is some thought that this is, and certainly there's a report from Gumeric in the IRJ in 2019, suggesting that this stuff is tolerable for patients, but patient number 2 just didn't like it, and I have to say I'm very much with her on this. The stuff is really quite unpleasant to inhale, so I think N-acetylcysteine does have a role, but primarily in the ventilated patient rather than spontaneously ventilating patient. There is an ongoing paper which is generating some data looking at N-acetylcysteine in bronchiectasis patients for inpatient use, but this is in peds and is ongoing and has yet to report. Another more novel strategy would be the use of heparin. This has been demonstrated as safe as far back as 2002, and it's thought to have an impact in terms of an anti-inflammatory effect by having an impact on the mast cells and the histamine response. It's certainly been thought to have an impact in terms of the has a mucolytic effect by having an effect on the polysaccharides, and that breaking of hydrogen bonds means that the airway, the sputum is less viscous. And there is some more recent data which has been published in pulmonary pharmacology and therapeutics, and this suggested that you were getting some improved lung function as a result of inhaling unfractionated heparin in patients with COPD. So did we use it in any of our cases? Well, the bronchiectatic patient we didn't use it in, but we certainly used it in our asthmatic girl who was completely intolerant to the N-acetylcysteine. It's probably worth mentioning inhaled mannitol. There is some clear evidence that this will improve mucociliary clearance, but this is a dry powder inhaler, so I'm going to not necessarily talk about that as much. So what about humidification? So we can define that as our system for adding water to inhaled gases, and could be passive, i.e. HMEs, or active as the large volume nebulizers or passover systems. And again, I would reiterate the fact that bubble through humidification systems are viewed as inadequate. So what's the evidence out there to say that we can have an impact? Well, I think this paper is quite valuable because it highlights one key area to say that water is the main constituent of the mucus which we're trying to clear. So if you can improve the water content of the mucus by adding humidity to it, we're going to aid the expectoration of secretion. So what's the data out there to say that this works? Well, this is an old paper by my friend Joy Conway, who was looking at the use of humidification as a way of improving airway clearance in bronchiectatic patients. This is a study which is using a radiolabeled aerosol, and there was certainly she demonstrated that there was a significant improvement as a result of delivering using a humidification system to improve the airway clearance in these patients, and that was both in terms of the mucociliary clearance measured by radiolabeled isotopes and the weight of the sputum that was cleared. There is some more recent data which has been published by Hassani in terms of looking at bronchiectatic patients, and Harold Ray looking at the value of humidification in COPD patients as well. So let's talk about these in a bit more detail. So the Hassani paper took 10 patients with bronchiectasis with a 10-pack year history. They measured the level of mucociliary clearance using a nuclear medicine technique. This was polystyrene microspheres labelled with technetium. They used planar imaging to measure the level of clearance, and there was a significant improvement in terms of the mucociliary clearance in the patients with the humidification, and this was felt very much to be water related. And by water related I mean in terms of adding moisture to the mucus. The Ray paper, this had around 108 patients with bronchiectasis or COPD, and of these 53 were in the treatment group and 48 were in the control group, and they were randomized to usual care or humidification. And the intervention in this case was effectively a nasal high flow system. So the flow rate was around 20 to 25 litres a day, and they were only using this for 2 hours per day. And the patients on long-term humidification therapy had a significantly fewer exacerbations. That was 18 versus 35 days, which was viewed as which was measured as clinically significant. But they didn't measure the airway the clearance, so this is more of a clinical improvement. But what is of note, of the 41 of the 53 patients who were in the treatment group chose to continue on the humidification as they felt a benefit from it. So is there something to be said for the possibility of combining both humidification and in this case nasal high flow and aerosol delivery? Well, there is this paper by Dernier which raises the possibility. Now this paper involved a nasal high flow system and a nebulizer, either a jet nebulizer or a vibrating mesh nebulizer, were put onto the dry side of the humidifier, and then they were looking at measuring the actual level of deposition of particles within the lungs. And I think the point which is of interest, if you have a normal jet nebulizer in healthy individuals, you're looking around 15 to 20% deposition. Here you are only getting around up to 3% deposition. So I think in terms of using this as a strategy for delivering drugs to the lung, the jury remains out. Now, there is a lot of debate which goes on around this, and I'm still open to persuasion. But to my mind, putting a nebulizer on the dry side means that you end up with a wet aerosol going into a highly humidified, highly turbulent environment, and therefore that is not likely to facilitate drug delivery to the lung. It's not a good place for a wet aerosol to be. So, in summary, what we need to think about with our patients is, what is the issue with the patients? What are the current treatments? Are they adequate? Are there inhaled therapies which we can add to enhance both acute care and long-term scenarios? And there's still an awful lot more to come. There's still an awful lot more to learn. Finally, I'd like to highlight the upcoming speaker talking about withdrawal of NI or mechanical ventilation end of life. I can highly recommend Professor Anita Simmons as a great speaker with a wealth of knowledge on this subject. Thank you very much for listening. Bye for now.
Thank you, Matt, for an excellent presentation. I've got some questions for you, Matt. What are the effects of incorporating nebulization and humidification? It might be or along with autogenic drainage, so that combining physiotherapy techniques to get the best outcome.
Well, the nearest paper that I can get to for that is Joy Conway's paper, and that demonstrated an improvement in airway clearance. Although Joy's paper was not specific around autogenic drainage, it was postural drainage and FVT and something like ACVT. I don't think that there's been any specific work which I can think of when I was looking through the literature which looked at specifically autogenic drainage. However, it's about the principles of how we put humidity or enhancing the mucociliary clearance and the cough action. So by changing the viscosity, it will make the other treatments more effective.
I always love a little bit of autogenic drainage. I find it's a really satisfying technique. Next question. What do you think about the new recommendations on humidification for NIV of 11 milligrams, high flow nasal therapy 16 milligrams, and invasive ventilation 33 milligrams? Would you also
11 milligrams?
So the ISO standards are changing, and I've got someone sitting in the background that's an expert on ISO standards if we need clarification. But I think it's around about, what do you think about the new recommendations, which are for higher concentrations for the humidifiers to produce for NIV, high flow therapy, and invasive therapy? And would you propose something similar, so adding in humidification for mechanical insufflation exsufflation, even though the time frame that it's used is shorter? So there's quite a bit to digest there.
So adding humidification in for insufflation exsufflation, I think it's about how you get the humidity into the airways in terms of preparation for that airway clearance technique. So if you're spending 5 or 10 minutes on something, and you'll get rid of the superficial sputum within the airways, and then I wouldn't necessarily be worrying about humidification during that process, but I would worry about it afterwards, so that you can you've cleared the sputum from within the airways, and therefore you'll have better airway clearance thereafter. The first point, in terms of actual fluid levels, well, it's getting a balance right, and I don't have a particularly good feel for what level of objective figures that we should be looking at. I think it was around 30 milligrams ideally is the level to get to. Certainly over periods of time with stable patients on NIV, there is not a great need to put huge amounts of humidity in those patients. It's when the patients either have chronic soporific diseases like bronchiectasis, and there's certainly some evidence to say that they respond far better if they're getting enhanced airway clearance and humidity going into their lungs, or if you've got someone who has an acute exacerbation where their sputum load has gone up. So I think those would be the times when I'd be thinking about adding extra humidity in. And I don't think, I remember having long conversations with one of my colleagues about humidity levels. And I was getting excited about what dosage we should give, and her response was essentially, well, if they're dry, I'm just going to give them some fluid. And I think there's an element of pragmatism and sensible thought which would go along with that. So I think that would be my viewpoint in terms of if they're high sputum load, normally increased sputum load, or they're feeling dry, I'm going to put some fluid into them, and I can't give you a definitive figure as to how much.
And on that topic of being too wet, too dry, I just wondered what your thoughts are, because we quite often get this patient has excess upper airway secretions, we'll dry them up, but then you get people giving nebulized therapy to loosen secretions, aiming lower down, and you've got that sort of catch-22, and I wondered what your thoughts are around that.
I think I've come across this a number of times with some of the neuromuscular disease patients, particularly motor neuron disease patients approaching end of life, where people have given them a hyoscine to dry out their oral secretions, and then given them carbamazepine as a mucolytic at the same time. Well, there's a bit of this is you need to make up your mind as to which you're going to be doing. I take quite a simplistic view in terms of airway breathing and circulation. I want the airway to be patent, and what can I do to maintain the patency of that airway and keeping the mouth comfortable? So again, going back to that earlier point that I talked about in terms of the fluid with the mouth care, that is really important. So mouth care is not just about keeping the mouth moist, it's also about clearing stuff out of it. So if we get that balance right, you then don't have to worry about so much about some of the stuff which is going on in the distal lung.
And there's a question around, you talked about hypertonic saline and and other techniques that can be particularly nasty, and one of the side effects is that you can get bronchoconstriction.
Yeah.
How would you ensure that patients don't have that problem, or how do you assess for whether you should continue giving it without just sort of like prescribing it and then going home and having it and having a reaction?
So the normal patients in terms of hypertonic saline should be given a challenge within a supported environment, so that then we've got a safety net to be able to see how they respond. So they'd get a dose with spirometry before and after to see if they had an adverse reaction. That's the simple way. In an acute setting, they're monitored anyway. So we would be in a position to see how they respond, whether they get a degree of bronchospasm. But that's a sensible point in terms of making sure that any inhaled agent doesn't cause some increase in symptoms and bronchospasm.
And if the patient couldn't do spirometry, how would you assess for that?
I would be looking at clinical signs in terms of increased work of breathing and auscultation with bronchospasm, and how they tell me that they feel. I mean, listening to your patient is always an important thing.
That is. And from listening to what people have been popping in the chat, Matt, they've said it's been fantastic for what they got, and that they will be changing their practice. So I think that's all we want to do, is improve clinical practice. So thank you very much for your time.